male, he had an exertional chest pain, which was patient is not attributing this chest pain to his cardiac pain. He is very reluctant to say the symptoms, and he was not like he's differing that I am not as that so pain referring regarding the chest pain of cardiac sound. But on evaluation, we found that there are some ECG changes, and echo seems to be normal. Everything is normal. But this patient has no significant past history like hypertension, diabetes. There is no family history of any CAD. But incidentally, we found some ECG changes. We forced him to get a CT coronary angiogram. These kind of patients going for an invasive coronary angiogram, they will be very apprehensive and anxiety. They don't even get an angiogram done. But we advised them to get a CT coronary angiogram in our institute. So I want to explain the case scenario and what the objectives and how CT coronary angiogram is helpful in this kind of patients, and how it has saved his life. Okay. So the background of this scenario is an increasing CAD incidence in young adults. This patient is very young, around 39 years of age, and symptoms often are atypical on exertional. Conventional risk scores may underestimate the disease, as it doesn't have any risk factors contributing the CAD. And advanced imaging aids in early detection, which is very useful nowadays. He is a 39-year-old male, chest pain since 10 days on exertion, no diabetes, no hypertension, high clinical suspicion of coronary pathology. When we complained, this is based on the history and ECG. ECG doesn't look like not significant MI changes. There was an LVH strain pattern. We did an echo. There is one episode of accelerated hypertension in the history. So he was not in the follow-up for hypertension follow-up. So we thought there is an undiagnosed hypertension, young hypertension, which was not evaluated. And that may be resulting the LVH strain pattern in ECG. So based on his symptoms, we forced him to get in a coronary angiogram, but he was very anxious, and we advised him to get a CT coronary angiogram. So the CT coronary angiogram, generally nowadays in the lab values, they are giving only the calcium score. Most of the individuals are getting the CT calcium score. It is normal, and it's like already it is around 2000 or something like that. It is like a screening. They think CT coronary calcium score is just like a screening tool. And if CT calcium score is 0, they are not at all going for a CT coronary angiogram, some diagnostic centers. So they think that if CT calcium score is 0, this patient won't have any CAD or very unlikely to have a CAD. But when you see this case, his CT calcium score was 0 and there was a right dominant circulation, left main was normal. But we observed that LAD, there is an extensive disease. That we have, so the proximal LAD is around 25 to 50% stenosis, and the mid LAD is around 99% block. See, this patient, if he has not undergone any angiogram or CT coronary angiogram, this patient, I showed, we have done an angiogram, there is a full of thrombotic burden. He is about to one step ahead of going to an acute MI. Distal LAD is around 70 to 90%, and D1 is diagonal is also 50%. The Corad's classification is around 4. So these are the images which showing the CT coronary angiogram. You can see that there is like some contrast opacification or the contrast block in the mid LAD. Next. So what is the key learning from CTCA? 0 calcium score is never equal to 0 CAD risk. What I want to say. Soft plaques are vulnerable in young patients. Young patients, they don't have any calcium deposits in their coronaries, but by seeing the only calcium score, we may underestimate the lesions and we may say that this patient is free from CAD. So this is one of the cases. And CT-CAG effectively triads that to cath lab. So after doing a CT coronary angiogram, by seeing the disease in the LAD, we thought we counseled the patient, and immediately we took for the cath lab for a coronary angiogram. After repeated discussions with the relatives of the patient himself. So invasive coronary angiogram was done. There is a critical left anterior stenosis confirmed, and the TIMI1 flow compromise. There is almost a total cutoff. That is almost a 99% block in the LAD. Other vessels are normal, and this is actually the angiogram. So you can see there is a total cutoff in the mid LAD. And the previous one, and there is a full of thrombus burden. That means he is an acute MI. This is an AACS case, not a chronic stable angina or something like that. You can see that this is after stenting. We put one stent in the mid LAD. The flow is absolutely normal, and there is a distal flow there. You can see there is a diffuse disease. Young patient seems like a diabetic vessels actually. We have to evaluate this patient. The diabetic profile was totally normal. I think we have to evaluate when this patient is on follow-up for hypertriglyceridemias or hypercholesterolemias, familial hypercholesteremia or something like. So this is how we did a PCI anyway, guide wire crossing and balloon preludation and everything and stand deploying. So post-procedure outcome was very good. There was a TB3 flow, chest pain relieved, hemodynamically stable and no procedural complications. This patient is having a high thrombotic burden. We put an IV antiplatelet solo. The cardiac ICU monitoring and early mobilization within 24 hours. The patient comfortably discharged. And now, today only the patient, just now he came to the OPD after 15 days for a review. He is very comfortable. I just now saw the patient and came. That's why I was somewhat delay. And he is very comfortable and he is using DAPT. The main intention is 39 years getting a one stent is very bad for the patient also. It's not so good. But we can't avoid this. And the young CAD has been now been more prevalence. This patient is not so having any, is non-alcoholic, non-smoker, and there is no significant family history. So what the main discussion is young CAD often underdiagnosed. CTCA detects unavailable soft plaques. Imaging to intervention strategy improves outcomes. So do not ignore exertional chest pain in young adults. Zero calcium score never is equal to zero risk. CTCA is a powerful gatekeeper to the cath lab. Timely PCA saves myocardium and lives. Thank you. Thank you.